Greetings and welcome to this Antibiotics Mastery Curriculum. So here we discuss about the antibiotics from the initial basic knowledge to the advanced knowledge as on ICU management of common to uncommon and multi-drug resistant organisms. So the basic idea that we need to have is that antibiotics are system engineering and not pharmacology. That means antibiotics are approached as of syndromes or systems that the infection is involved and not just based on the pharmacology of the drug. All these references are taken from IDSA standard guidelines and Sanford policy guidelines. This is completely for educational purposes for physicians in their hospital inpatient practice. This is medicine beyond Harrison's, and let's get started. So the core philosophy of antibiotic use is that it is mainly the source control. So antibiotics does not cure the infections; it just helps to control the source. So host plus source control leads to the cure. Antibiotic only buys time. So no source control is no success. So for example, if the patient is having an osteomyelitis and that is not being directed, but the blood culture is growing some organism, probably Staphylococcus aureus, and you have started the patient on cefazolin IV and not eradicating the source of osteomyelitis, not debriding the wound properly, will not even result in the cure of the infection. The patient will again go on to the repeated infections or succumb. So delayed is harm. So antibiotic harm is delayed. So today's wrong antibiotics is tomorrow's MDR ICU. So if a patient who is having resistant to ESBL, that is ESBL, extended spectrum beta lactam is producing E. coli. For example, if you're treating it again with ceftriaxone or Magnex 4, it will get resistant to that antibiotic, and then they gradually become meropenem resistant or carbapenem resistance. So the next time the patient acquire infection, it may be an MDR, or in the way it will result in basically an MDR ICU. So stewardship is the future patient advocacy. So current choice of antibiotic decides the current patient's cure, whereas the upcoming future patients lifeline. So define the problem. It's 70% of the expertise. Is it real? So whether the infection is real, that is where the clinical decision is of the key importance. So IDA writers spend more time here than on the drugs. So whether there is fever, whether there is leukocytosis, whether there is organ dysfunction, is there localizing signs, is there radiological feature supportive of infections, is there cultures positive or from the sterile sites such as blood culture. So blood CSF or sterile sites where usual organisms isolated are almost always pathological, whereas organisms isolated from urine cultures can be pathological or non-pathological. Needs clinical discernment to identify it. So it is the constitutes 70% of the expertise before giving an antibiotic. So colonization is not equal to infection. So for example, blood culture, one bottle Arabic shows growth of English negative Staphylococcus aureus. You did not treat that because it may be just a colonizer from the skin that would have gone translocated into the blood during sampling. So inflammation is not equal to infection. So treating non-infection is the best antibiotic area worldwide. So try to avoid that in most cases. So when there is fever, there will be an infection. If there is leukocytosis, a marker of infection. Go for other markers such as procalcitonin for titration or for de-escalation of antibiotics and not for starting antibiotics. So whether there are organ dysfunction, whether the patient is in sepsis or septic shock. Is the radiological finding supportive, for example, fat standing in the kidneys or in the colon, or there are pneumonia patches in the lungs, or whether there are meningeal enhancements, leptomeningeal or pachymeningeal enhancements in the brain suggestive of meningitis. All these are features suggestive of infections, or if there is an abscess localized, psoas abscess, or collection, air pockets, all these are radiological findings suggestive of infection. So syndrome is and severity. So antibiotics are approached based on the syndromic approach, not based on the just the antibiotic of choice. So always think in syndromes and not organisms. So whether it is pneumonia, lung infection, community acquired or hospital acquired, whether it is urosepsis, whether it is intra-abdominal sepsis, whether it is skin and soft tissue infection or CNS infection. These are the broad six syndromic approaches that are usually needed for a physician. CNS infection can be encephalitis, meningitis, viral meningitis, viral meningoencephalitis, tuberculosis, Japanese encephalitis. I think skin and soft tissue infection can be just cellulitis or erysipelas or necrotizing fasciitis or just a skin abscess or a pyoderma or a furunculosis or carbuncle. Intra-abdominal sepsis could be an intra-abdominal abscess, colitis. all these peritonitis, urosepsis could be pyelonephritis, just there could be a stone causing hydrourethral nephrosis, cystitis, hospital-acquired infections or ventilator-associated infection, pneumonias, community-acquired pneumonias. So guidelines are syndrome-based and not based on the organism that is isolated. So severity determines how much you can afford to be wrong. If the patient is stable, try to use the narrowest possible antibiotic. If the patient is in sepsis, try to go for early broad. If it is septic shock, go for the broadest spectrum of antibiotic. Do not miss any coverage. Later, you can de-escalate based on the culture sensitivity pattern. So host factors, this is where the common junior entry level doctors, physicians fail. So IDSA always stratifies by the host. This is a host factor. Immune status. If the patient is diabetic, it itself increases the risk of multi-drug resistant organism or recurrent infections. CKD, cirrhosis, steroid usage can lead to immunosuppression. Transplant patients already would be on chemotherapy or on biologics or rituximab kind of drugs, which causes low lymphocytes, leads to infections with viruses such as BK polyomaviruses, neutropenia. Each of these changes the pattern of microbiology that the patient could have uh, conquered. So, prior exposure in the last 90 days is the strongest predictor of resistance. If the patient is exposed to a ESBL E. coli in the last 90 days, which was not appropriately treated, now it could have become a carbamazepine resistant E. coli. So, more important than hospital biogram is the prior exposure of antibiotics in the last 90 days. Then indwelling devices. So Foley's catheter, central line, ventilator and stents, prosthetics. All these devices creates biofilms where the organisms stays and colonizes. Antibiotics have poor penetration into the biofilms to eradicate these organisms completely. So whenever you find a device that suspicion of infection and that you need to remove it and always remove it. So removing itself creates a lot of difference in the treatment management and the patient could become afebrile, responding to antibiotics faster. So central line, remove it. Foley's catheter, you can remove it. Ventilator, you can try to remove it. Prosthetics, also try to sterilize it or remove it. So predict the pathogen is the light scale. So predict the grams in community versus hospital or source. In case of community acquired pneumonia, it could be the streptococcus or H influenza. ICU, if the patient is in ICU and they have acquired pneumonia, it could be pseudomonas or MRSA. In case of urosepsis, it could be just E. coli or Klebsiella. Intra-abdominal is almost probably a polymicrobial organism. So before the reports arrives, you should suspect whether it is ESBL or MRSA or carbamazepine resistant Enterobacteriaceae. You must have the discernment to find all these kinds of resistance bugs based on your clinical judgment. If you can predict ESBL, you are already ahead of 90% of the physicians worldwide. So empiric antibiotic selection. This is the damage control and not perfection. So you have to control the damage initially. So you should cover the likely pathogens. You should avoid unnecessary overlap. Avoid blind carbamazepines. Don't just go for blind carbamazepines on the first line when the patient is stable. Think in coverage buckets and not based on the organism. So these are the 5 empirical buckets. Each kind of syndrome could present with. So each syndrome activates different buckets. So gram-positive organisms have different antibiotic spectrum and of use. Gram-negative organisms have different antibiotic spectrum. For Pseudomonas, specific antibiotics are approved. For anaerobes, different antibiotics are given. For MRSA, different antibiotics are given. So these are the 5 empirical buckets. Previously, we discussed about the 6 clinical syndromes associated with infections. Now we are discussing about the 5 empirical buckets, which have different kinds of antibiotic usage in each of this. So pharmacology is there are usually these 4 classes of drugs where the killing mode is different. So this you must need to remember. It is non-negotiable thing to remember. So for beta lactams, it is always the time-dependent killing. So how much duration it is present in the body is very important. So you can give, for example, if you give a piperacillin, you should give it an extended infusion time, maybe like 1 hour, so that it keeps circulating in the body for a long time and causes clearance of infection. That's why piperacillin tazobactam is given 6th hourly or 8th hourly. So that more time it remains in the blood, more infection is getting cleared. Example for aminoglycosides is just concentration dependent. One high dose of aminoglycosides such as gentamicin or amikacin will just clear off the infection. Fluoroquinolones and vancomycin are area under the curve dependent. You should maintain the uh, concentration of the drug above the minimum inhibitory concentration and well within the area of under the curve so that uh, there is a good response to this antibiotic. So these are very tough to titrate, so hence not preferred initially. So ICU per that is dose is not at all equal to the exposure. So based on the each antibiotic type of antibiotic have different killing mode and such that you have to modify the dose and exposure. So extended infusion of beta lactams is the custom. You should look for augmented renal clearance in specific patients in dialysis or continuous renal replacement therapy. Hypoalbuminemia may result in decreased binding of antibiotic to plasma protein and getting cleared of so faster. CRRT affects clearance such as CRRT constantly removes the antibiotics from the body, circulating it from the body. Hence, it clears off faster. So maybe increased dosage of time of antibiotics should be given to the patients. So culture interpretation is another big art. You have to predict the culture even before you get obtain the report. So when the patient presents to the emergency, when you are taking the blood culture, you must know based on the clinical spectrum, the syndrome, and the five common kinds of organisms that could possibly present, and for the site of infection, what organisms could be present, and you must suspect it, and accordingly you must start the antibiotics. So when you see a culture report and you see an organisms which is expected for that culture, for example, for a patient with urosepsis, you expect an ESBL E. coli, then it is expected. Whereas if you expect a coagulous negative staphylococcus, and that is not probably from the urinary tract, maybe a skin contaminant. So whether it is a skin contaminant, whether it is single or polymicrobial, if there is a polymicrobial growth, multiple organisms could be identified. For example, from a wound infection, blood culture can show protease and maybe Staphylococcus aureus, multiple infections, even Klebsiella, sometimes Pseudomonas, polymicrobial infections are possible, especially in the skin and soft tissue infections. So never read row by row. There will be many antibiotics given for a single organisms. So never read the antibiotics row by row. That is whether amikacin, gentamicin, carbapenem. They'll be given in an haphazard order. Never read it in a row. So always look for signatures. ESBL signature is ceftriaxone. Carbapenem sensitivity is based on meropenem. Quinolone resistance clusters. So based on this, you have to look for whether the what kind of organism is this. So de-escalation is based on the narrowest option available and the possible narrowest and adequate option. So de-escalation is a skill and it's not a weakness. So de-escalation is very, very important in the antimicrobial stewardship to prevent future resistance. So always stop combo when it is not required. Switch to oral as soon as possible when the sepsis or shock is resolved. So definitive therapy, this is where IDSA shines. So it is the what is a definitive therapy for an infection? So definitive therapy, there is no definitive therapy for an infection in a guidelines based thing. So it is always based on the individual and the patient based approach. For this patient, you must choose the narrowest effective antibiotic agent with the best tissue penetration of that site of infection, with the best evidence for that syndrome and the lowest collateral damage. If these fulfill, if your antibiotic of choice fulfill all these four criterias, then it is the definitive antibiotic of choice for that infection. So always prefer shorter duration. So for gram-negative bacteria, the generally recommended duration is 7 days. Community-acquired pneumonia it is 5 days. For ventilator-associated pneumonia is 7 days. For pyelonephritis, it is almost 7 to 10 days. So longer antibiotics is not equal to better. So when an antibiotic is not responding for 7 days when you give it, it is highly likely that it won't respond for when you give it more than 10 days also. So better to change or do some repeat cultures to identify what is the actual organisms. Or you may dealing with a wrong bug. So stop rules. Every antibiotic must have an indication, the day of therapy, stop date, and the de-escalation plan. So all these are very very important. If not, it's bad medicine. So advanced, you must will in the further videos we'll look for the ESBL prediction bedside methodology, carbapenem resistance mechanism, biofilm infections, the combination therapy myths, antibiotics and CRRT, ICU antibiogram usage. So this is based on completely based on Sanford and the IDSA guidance. In the upcoming modules, we'll discuss one by one based on the syndromic approach as well as based on the antibiotics, individual antibiotics and its spectrum of activity. And finally, we will conclude with how to interpret an antibiogram and its use cases and which antibiotic to choose in different case scenarios. So this is this first module of this series of antibiotics. This is Medicine Beyond Harrison's. Let's thank you for watching.